Hello, and welcome to this PrecisCa mini breast tumor board on breast cancer. My name is Dr. Reshma Matani. I'm a breast medical oncologist at the Sylvester Cancer Center, University of Miami, where I co-lead our breast cancer program. It's my pleasure today to be joined by several well-renowned breast experts who I will now ask to introduce themselves.
Good afternoon, everybody. I'm Dr. Maxine Jockelson, and I'm the Director of Imaging at the Evelyn Lauder Breast and Imaging Center at Memorial Sloan Kettering Cancer Center, and I am a breast imager.
Hi, everybody. Ruth O'Regan. I'm the Chair of Medicine at the University of Rochester Medical Center, and I'm a breast cancer medical oncologist.
Hi, I'm Chirag Sharma, radiation oncologist. I serve as Director of Breast Radiation Oncology and Clinical Research at the Cleveland Clinic Taussig Cancer Institute.
Hi, I'm Terry King. I am the Chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Cancer Center.
45-year-old woman who has a BRCA1 mutation. She has a history of a left-sided node-negative, triple-negative invasive ductal cancer and underwent bilateral mastectomy and total abdominal hysterectomy and oophorectomy based on the BRCA status. 4 years later, she develops a lymph node recurrence in the in her axilla, not stated here, but we'll see next. And she's progressed through multiple lines of systemic therapy. And the question is with regards to systemic therapy management. She currently has presented with a palpable lump in her left axilla 4 years after her original diagnosis, and her current status is ECOG status is 0. Generally healthy other than a mild hypothyroidism. Her gynecologic history is shown here. She has no toxic habits and has a family history. Mom died of lung cancer, maternal great-grandmother with ovarian cancer. When she originally presented, she had that mass in her left breast. She was 38, confirmed by mammogram, biopsy, ER weakly positive, PR negative, grade 3 invasive ductal, HER2 negative. On lumpectomy, it's 1.8 centimeters, node negative, ER again weakly positive, PR negative, HER2 negative. She completes treatment with adjuvant doxorubicin, cyclophosphamide, and a taxane, and shortly after, adjuvant therapy is found to have a BRCA1 mutation, and then goes on to have a bilateral mastectomy and prophylactic removal of her ovaries. 4 years later, she palpates a lump in the left axilla, and now this time it's biopsied, and the ER is much higher, greater than 50%, PR is negative. HER2 is 1+, and PD-L1 for some reason is done, actually subsequently later done, but was 5% by the SP142 Ventana assay, so on immune cells. The imaging showed a large conglomerate of hypermetabolic left axillary, retropectoral, and supraclavicular adenopathy, which is quite apparent, but I'll ask Dr. Jockelson to show us.
Certainly, yes, when they described a lump, you think there's going to be some small nodule, but what she has are very large and irregularly enhancing rims with low attenuation in the mass, suggesting that there's a great deal of necrosis. Usually when I see things like this, I think they're going to be triple negative cancers. It's just a very aggressive looking tumor. See it both in the left axilla, left retropectoral, and the supraclavicular region. Mm-hmm. So very big necrotic tumors.
Mm-hmm. Okay. So in terms of her treatment, recall she had adjuvant therapy, and then at the time that she had the recurrence in the nodal areas, given the ER positivity and no visceral disease, she did receive a trial of letrozole and palbo. And then as you see all of her additional treatments, it seems like the physician who treated her tried to kind of keep their foot in both camps per se. didn't respond to hormonal therapy, CDK4/6 inhibitor therapy, then based on the fact that it was behaving more like a triple negative tumor, switched to more of an approach with immunotherapy based on that PD-L1 positivity. Unfortunately, it seems like the atezolizumab didn't go so well, autoimmune pneumonitis, which resulted in hospitalization. Then based on the BRCA finding, a PARP inhibitor was used, and she did have a response for about 8 months and then progressed, and then has gone through multiple systemic therapies, including sacituzumab, in the hopes that this would work as a regimen for a triple negative patient, although there are some data currently, or a trial ongoing, looking at that agent in ER positive disease as well. A retrial of Pembro as immunotherapy, just given the hope that she wouldn't have an issue with pneumonitis again, and did fine from that perspective, but unfortunately didn't work. Had radiation to these multiple large masses that were causing local issues, and most recently has had that massive progression in the axilla superclav nodes. Here we really see the need to do some profiling on this tumor, and this is the result of her profiling, which interestingly shows AR by immunohistochemistry positivity 1+. The mutation was actually a BRCA1 mutation, which isn't shown here. This says BRCA2. Again, PD-L1 on immune cells, 5%, no PIK3CA mutation. So a tough situation in terms of a tumor that is behaving quite aggressively without any visceral disease, but certainly very symptomatic from these large, bulky lymph node areas. Dr. O'Regan, I'm curious to see how you would approach a tough situation like this.
Yeah, I guess my first question would be, how recently was the disease biopsied, and was the genomic sent on, what specimen that was sent on, because obviously, you can acquire certain mutations. So my thought would be, so she doesn't have a PI3 kinase mutation, so obviously alpelisib is not an option for her. If the cancer is still estrogen receptor positive, I guess I might think about using everolimus here, either with exemestane or tamoxifen. I think you can use with any endocrine agent, whichever one she hasn't had before. So I might try that. And then, I think as far as chemotherapy, she hasn't had liposomal doxorubicin, that might be an option for her. But I'd be kind of loath to go down more chemo route, because it doesn't really sound like she's benefited that much at any point from the chemotherapy. The other thing, obviously, a clinical trial would certainly be an option for her. She's probably reaching into the kind of phase of phase 1 trials at this time point. The other drug just to think about, though, which we talked about earlier, was the trastuzumab deruxtecan, because there obviously are trials ongoing in HER2 normal breast cancer. So that might be something to think about for her as well. So they would be my thoughts. But, obviously heavily pre-treated with chemo-resistant disease, there's not a huge amount of options here.
Mm-hmm. Would you be very enthusiastic about targeting the androgen receptor, given that AR positivity? What's your experience been?
First of all, the expression, well, it is over 10%, so you could think about it. The data in triple negative breast cancer, it's a single agent, it's fairly modest, I think. And then, we have a fairly recent trial in ER positive breast cancer that really didn't look that encouraging either. So it would be a thought, but I think that wouldn't be my top choice here, I have to say.
Mm-hmm, mm-hmm. From a local therapy options discussion, I'll ask both of you, Dr. Shah and Dr. King, to comment when her disease was perhaps not as bulky in the axilla and mainly lymph node involvement. Would either of you have been more aggressive in going after this disease from a local standpoint? Now I think it's clearly going to be tough, but maybe previously when it was more axillary involvement.
So I think we have definitely learned that isolated axillary failure is an uncommon and rare event. And most patients that present with axillary failure either have synchronous metastatic disease or will develop metastatic disease within a relatively short time interval. And so certainly if she had that bulky disease when she presented, certainly, you would have hoped that systemic therapy would downstage that disease and that you would potentially have had a window to do lymph node dissection for local control. But it really just depends on what that time interval was between, her initial response and the development of metastatic disease.
Mm-hmm, mm-hmm. And she's had some palliation with with radiation to paraspinal mass and I think to another area of lymph node involvement. Dr. Shaw, do you have anything to add?
Yeah, I mean, I think the only thing to Dr. King's point is that window is important. In some of those cases where there's a borderline resectability, we will consider actually neoadjuvant radiation in consideration with Xeloda in some cases to try to make surgery more feasible. So in a case that was borderline, we may consider. The other thing is she's likely, given the anatomy of the situation, developing malignant lymphedema. And so one of the things we sometimes do is even if we see something heading up, we would actually prophylactically treat it if it wasn't a surgical plan with radiation therapy to try to prevent that.
Mm-hmm, mm-hmm. Okay, great.
Can I bring up, Dr. Shaw brought up hyperthermia, which I just wrote to him is one of my favorite and I think very underutilized modalities. And I've had experience in patients like this. We used to use an ultrasound device and we would this is a very necrotic, so it's a hypoxic tumor. So we would actually give them small doses of radiation since most patients had already had enough, and give them hyperthermia with platinum simultaneously. And even with these big axillary type of tumors, I've seen amazing local results. I mean, whether that prolongs or improves survival, but I've seen a lot of success in tumors like this when using hyperthermia, which kind of went away at one point because insurance didn't cover it, things like that. But it's miraculous in some of these tumors.
Mm-hmm, mm-hmm. Well, thank you all for your input on that tough case.